Welcome to our special live streaming series, COVID-19 Frontline on CGTN. I'm Zhou Yun. COVID-19 Frontline, the special live stream from China and around the world to share their thoughts and experiences in the prevention, control, diagnosis, and treatment of patients with COVID-19. And apart from expert discussions, we also take questions and comments from followers on various social platforms, such as CGTN app, the official website, CGTN official account, and on Facebook, YouTube, Twitter, and Sina Weibo. So feel free to leave your comments as well as questions on those platforms that I have just mentioned. And also, when you do leave them, please use the hashtag of my opinion on COVID-19. We look forward to your sharing. And today we have medical doctors from China, the United States, as well as Russia joining us. And all the three doctors from China all have frontline experiences in fighting the pandemic in the previous epicenter, Wuhan. So they're all from Beijing Hospital. Thank you so much, doctors, for joining us. And now let me introduce all of them. So we have three doctors from the Chinese side. They are Dr. Xu Xiaomao, who's the Deputy Director of Pulmonary and Critical Care Medicine at Beijing Hospital. Thank you for joining us, doctor.
Hi, hello.
And hello. And also Dr. Chang Zhigang, who's the Deputy Director of Surgical ICU at Beijing Hospital. And Dr. Wen Li, who's the Assistant Professor of Emergency ICU at Beijing Hospital. Thank you so much for joining us, doctors. Thank you. And we also have 6 international medical experts joining us, and they are, the beautiful lady is Dr. Li Jin, who's the Director of Neuromuscular Laboratory and Director of Headache Center at Westchester Medical Center at New York Medical College. Thank you for joining us, Dr. Li. And also we have Dr. Henry Chen, who's the President of Samos IPA, CEO of Excelsior Medical Group. Hello there, doctor, for joining us. And also we have Dr. David Zhang, who's the CMO of Eastern Chinese American Physicians IPA and also Director of Excelsior Laboratory. So thank you for joining us, Dr. Zhang. And also Dr. Jonathan Lobowitz, who's a pulmonologist and CMO of Excelsior Medical Group. And also Dr. John Ashkar, who's a pulmonologist at Excelsior Medical Group. Last but not least, we also have a guest from Russia. It's Professor Sergei Kolesnikov. He's the member of Russian Academy of Sciences and Distinguished Scientist of Russia, also professor of Lomonosov Moscow State University. So thank you so much for joining us, ladies and gentlemen. And we also have a special distinguished guest joining us today is Mr. Zhou Guolin, who's the Science and Technology Counselor at Consulate General of the People's Republic of China in New York. So thank you so much for joining us, Mr. Zhou. So why not we just start with you for you to have a few remarks to deliver to us. Thank you.
Thank you, Ms. Zhou. Very happy to participate in this very important event. You see, now I'm working in New York. New York is now becoming the real epicenter of the pandemic worldwide. It is a very serious problem. You see, I just checked the number of all of the confirmed cases in the states of the United States. That is about 890,000 cases confirmed. All of these, there are about 50,000 people died because of the infection of the disease. So it's a very serious problem. In this case, we have to join hands from all of the continents, not only from China, but also from USA, also from Russia and other countries. We need to join hands to cope with this serious problem. So this is the first comment I want to express to all of you. And second, we need to share experiences. You see, in China, we have really got this pandemic to be contained since late January through April sometime. So now even the epicenter of Wuhan has been reopening again. So this is very good news for all of the other countries in the world. And we need to share our experiences in China, for example, in terms of detection, in terms of quarantine, in terms of treatment, in terms of follow-up actions, what we need to deal with. So this is something we can share experiences and thoughts and ideas and whatever. And the third one is I want to say I would like to strengthen, we need to cooperate more in this regard. For example, in terms of public health, even policy making, as well as to make the public awareness of all of these infection diseases, how it spreads and how we should be making more attention to it, as well as in terms of research of vaccine. and also to make the very appropriate medicine to contain this coronavirus. So this is very important for us. I would like to also take this opportunity to thank all of you, the very distinguished experts from China, from the USA, from Russia, and also in particular to thank the CGTN to have this very important platform to bring us together to share our experiences. I thank you so much. You see, I am now in New York. We are just in the epicenter of this pandemic. But anyway, we will try to do our best to strengthen cooperation among different countries, in particular for the partners of all different research institutions for better cooperation in the future. Thank you very much, Ms. Zhou.
Thank you so much, Counselor, for your greetings as well as your messages. And now, without further ado, we'll just start the discussion for today. And first of all, how about we have Professor Kolesnikov to share with us some of your analysis and your observation of the current situation of COVID-19 worldwide. So, Professor, please go ahead. You need to turn on the audio before you speak every time, and this is the same for every guest. Thank you. We still can't hear you. You're now still muted. Now it's good.
Okay.
You're good to go.
Okay. So, do you see the slides?
Yes, we can see the slides perfectly.
Yeah. Okay. First of all, one question which I have on current data on coronavirus and COVID-19. Now it's current data about the situation. How many infected? How many ill? How many total deaths? And very surprising figure is about USA, because there are only 267 cases announced to be registered today, and only 7 deaths. It's about 100 times less than it was previous days. Congratulations to USA, or it is a mistake, I don't know, really. And in Russia, we have now very interesting situation. We have now a sort of thieves, because we have now about 5,000 to 6,000 cases daily, not rising during the last 4 days. It's for us, it's very good good data, and we have less than 1% deaths per the infected people. And if you see logarithmic curve, you see that the curve is very low, and it's very good too for us, because we can prepare our healthcare system to the new cases of coronavirus and COVID-19. And daily new cases, as I said, was stabilized, but we don't know. Perhaps it will be more cases next several days. Because of that, quarantine is still in Moscow is very severe, but in other regions of Russia, it's very mild, I can say. So we'll see in the next day what will happen. It's information about Russia, and I am very glad that in China, where my grandson is living, the situation is very good during last month or 3 weeks. Congratulations to our Chinese friends. And in this, I have some questions, of course, about the situation in China. First of all, about Chinese medicine, of course, because there are few information in Western medical literature, few information about what was the role of Chinese medicine in the treatment of COVID-19. It's a very interesting question for us, because there are big discussion in Russia about the so-called proved medicine, that Chinese medicine is not proved because it must not be used in, in some cases for Russian traditional medicine. So it's a very important question for our physicians. About so next question about delayed effect of.
So maybe we can answer the question one by one because we have so many.
Okay.
So yeah, let's just answer the first question about the medicine that or the treatment that we have here. So from the Chinese side, who's going to answer that?
Okay, I'll answer this question about the Chinese traditional medicine. Right?
Yes.
Oh,
yes.
Okay. In our patient, we have about 100 patients. About 97 patients use Chinese traditional medicine, but not just along the traditional medicine. We also use drugs machines like antivirus medicines like others. So it's hard to say. It's just because of the Chinese traditional medicine is work. I think it's help. It's help. So some Dr. Zhong Nanshan have he said Chinese traditional medicine will help to control this virus. So I think it's a help, but it's a combination with other medicines. That's all. Thank you.
Okay, and second question is about have you any information, because you have been first in conferring the COVID-19. Is there any postponed, delayed effect of the COVID-19? Because it's very important how to manage patients who already recovered from COVID-19, so-called recovered from COVID-19.
Mm-hmm. Mm-hmm. So it's about reinfection, right, or resurgence of the COVID-19 after they are, as you said, recovered, right?
I repeated the question. You said recovered or reinfections disease, right?
No, not reinfection. Not a question about reinfection. In our medical society, there are strong belief that COVID-19 SARS virus cause several damages, not only in lungs, not pulmonary complications, but in kidney, in some other organs, in liver, and so what is your experience?
Okay, so what's the recover after this disease, right? We actually, in our opinion, this disease was mainly affected lungs and other organs like heart or liver, but the main organ is lung. So I'm a lung doctor, so I focus on the lung recovery. A lot of people, when they discharged, there's some lesions still remain in chest CT. So after that, we will suggest this patient do some rehabilitation before when he stay in the hospital. If he can do some rehabilitation, we will do some rehabilitation. And after that, we'll let them discharge. We'll follow up this patient pulmonary function test, chest CT, and arterial blood gas analysis. So this is how we follow up this recovered patient, I think. Especially, I'm care about this. The patient still have lung lesions like a fibrosis. Maybe they will influence the patient life qualities. So that's I am focused on this. Thank you.
Mm-hmm.
And another question, perhaps not for you, but some suggestions are that virus from USA, from Milan, from Italy, from Wuhan is different. They are different viruses. Because of that, the different rate of mortality, different rate of the severe complications of these viruses. Is it true or it's false idea?
It's a really tough question. So our doctors, is it like different viruses in different places around the world because they have different maybe recovery rate or mortality rate? So maybe
Yes.
who can?
Okay. I will answer this question. Yeah, we know it's a different virus type in a different country. I think the article is published. There is a three type of the virus A, B, C. There's difference in America, USA, Italy, or in China. Yeah, so I think it's virus mutation makes the different mortalities. One is a virus mutation which may cause a different mortalities and infections rate. But the other way is how the different country treats the patient management. I think it's measurement is very important. So that's a different infections rates and mortality rates. So it's not the virus mutation.
Okay. Thank you, Dr. Xu, and thank you, Professor Collis Knockoff. And now how about we turn to the lady, Dr. Lee. Do you have any question for our doctors, or do you have anything to share with them?
Sure. Okay, thank you. It's a great opportunity to be part of this this podcasting. At my hospital at Westchester Medical Center, so we're at the suburb of New York City, and we are, one of the main epicenter actually for the COVID-19. The first, actually, the New York, the community spread COVID was from Westchester County. That was a lawyer who actually worked in the commute to Manhattan. So that was one of our city New Rochelle, and from that incident, we actually has a pretty significant community spread, and that synagogue, that's a Jewish church. That from that synagogue, we have actually about 100 patients spreading from this community spread. So, I mean, Westchester Medical Center, we are one of the we're the flagship of WMC Health. We have more than 10 hospitals, and we have been treating our hospital since the start of the pandemic of COVID. We have been treating a large number of COVID patients, and during this process, there are a few things has been. I think the American colleague probably had the same experience. In the early March, we stopped basically postponed all the outpatient and postponed all the elective surgery, and basically reserved the resource to treating the surge of the COVID patients. Mm-hmm. So we basically, first of all, we doubled the ICU bed. We convert all those reserved bed, including all the ICUs and the different ICUs. And we do have a new ambulatory building, which has about 40 the ICU bed, which initially was designed for the post-op use, but for the ambulatory surgery, and then was converted to, during this pandemic, we convert to the acute bed, and also all the operating rooms, they all convert to the acute care. So at the surge of this pandemic, I think our hospital have over 100 ICU patients. And the good news is, I think since early March, and with the effective social distancing, and wearing the mask, with all those the CDC recommendations, I think we're really seeing the flattening the curve for the past 2 weeks. We see the steady number of the admission. At the same time, the number actually was steadily decreased. And so the admission rate has been decreasing, and so we do see the quite effective treatment, and also the preventive measure is really taking effect. So as a neurologist, my question is, we do see neurological complications from COVID-19, and we're really talking about severe encephalopathy. We see the ischemic, the cerebral event. We see a lot of strokes, and those strokes we do see them in the not typical the elderly who has the comorbidities, and we do see the severe stroke from young, who has basically with healthy young patients, and they came with significant large vessel infarctions, stroke, and we also see the surge of the increased neurovascular condition, which including like myasthenia gravis, and they have exacerbations. And we do see Guillain-Barré, which is another quite a severe neuromuscular disease. We do see the higher comorbidity with COVID. So my question to our Chinese colleagues, and that's your experience in Wuhan, do you see many cases of a stroke or any neurovascular conditions?
So who's gonna answer that?
Dr. Chang, yes.
Okay. We during our treatment, yeah. First, I'm glad to hear that your curve have been flattened, and yeah, it's very like early stages in Wuhan situation. And for your question, during our treatment of over 100 patients, you know, the central nervous system, the syndrome is not very high. We have some patients may have some neuropathy, maybe because of anxiety or hypoxemia caused neuropathy. In one, I have a case report. I heard a case report from Beijing Tiantan Hospital. They have a patient with coronavirus infection of the brain, and they used they have a biopsy. They tested the coronavirus nucleic acid from the fluid, the brain fluid, and it is positive. Only heard of one case, but you know, recently more and more cases were reported with the patient with you know, the smell problem. That may be one cause of the one cause of the, you know, the path of the infection maybe. Yeah, I think most of the patients with brain problem may be due to the hypoxia.
Okay, thank you, Dr. Chan. So what about other doctors from New York? Do you have any questions or do you have anything to share with the doctors here in China? Please go ahead.
Yes, I do. Hi, John Ashtra, pulmonologist, intensivist at New York Excelsior Group. I have a couple of questions actually. First, I want to comment on Professor Sergi question. What we're seeing as a follow-up after discharge for a patient with COVID. I think like one of his question was, how long do you follow up those people from different type of disease like DVT, heart problem? Does those people need to have like cardiac testing after discharge? Do we need to keep doing venous Doppler for them? How often do we do it? Like the follow-up for those patients is a question mark now. We have different protocols over here in the United States. The second question, do you want me to go one by one or?
It'd be great if you can ask one or two at a time, not too many at a time.
So that's the first question, like follow-up for those patients, you know, from a cardiac point of view, do they need to have like a stress test after discharge from the hospital? Do we need to in a Doppler for them? Majority of those people have a very high D-dimer in the hospital, and the autopsy studies did show a lots of microemboli or microthrombosis, which in part could be related like for thrombosis in situ more than like showering emboli, you know, tending to increase pressure and to weak mismatch. What's your experience on that? And I'm sorry, before we start, like majority what we're seeing over here is more is ground glass opacity on the X-ray more than fibrosis changes. For those people when we see them even in ICU, they still have a very good compliance in comparison to people who have fibrotic changes.
So, Dr. Xu, who should answer this question, you think?
Answer these questions. The question is about follow up the thrombosis event. Yeah, in our patient, we find there is a lot of patients have coagulation dysfunctions. Our patient, about 17 to 80 patient, 60 patient, 60% have the coagulation disorders. 17 to 80% patient have D-dimer increased. So so we have the care about the thrombosis events, but we can't. Unfortunately, we can't have the CTPA or ultrasound available, so we can't confirm how many thrombosis event happens. But we do have read some papers. The study from the Holland ICU hospital. There is 184 patients in the ICU. There's 31% of the patients have the thrombotic event, and 27 was a VTE event. Only 3.7% have the thrombotic event, arterial thrombotic events. So I think this patient, because they have the high risk for VTE factors like the excessive inflammation, hypoxia, immobilization, and the DSE, like something like that. So this is what we very care this patient. We cannot do the CTPA ultrasound, but we did VTE prophylaxis for almost every patient if they don't have the they don't have the contradictions. So and I think this patient should be followed up after at least 3 months with the discharge. And for the lung disease, for the interstitial lung disease or lung fibrosis, I think we should follow up longer, 3 months, 6 months, or even 1 year.
Okay, thank you so much, Dr. Xu.
Might I make a comment? I think they were talking about the embolic thrombotic event. I think I mean, our experiences, it does happen in lung, and certainly at the same time, it does happen in the brain as well. And currently, we do put those patients on anticoagulation. So just to follow Dr. Xiaomao's answer, what percentage patient do you really put them on anticoagulation if you really suspected the DVTs or other embolic event?
We will use PADU's score. Every patient in our world, we will use a PADU score to evaluation the VTE risk. And if this patient, the score is more than 4, we will use this anticoagulation to prevent the VTE. So in my, I think about 70% of the patient, we use anticoagulations.
I'm sorry, I just want to go back to the question. Like, my question was more after discharging those patients, what's the percentage of people who you see coming back with a thromboembolic disease, like with PE or stroke or anything after discharge from the hospital, not while they were admitted to the hospital? You know, talking about follow-up after discharge, how long do you keep following them from thromboembolic event, and how many of those patients did develop cardiac problem after discharge, not while they are being treated for COVID?
Okay. Actually, we don't have the data because we just work there 3 months, and most of patients just leave the hospital about the longest is almost 2 months. So we didn't hear about the patient have the pulmonary embolism events or VTE events because we will, if this patient get worse, we'll get a message from the other side. So I'm sorry, I can't tell you exactly number.
Mm-hmm. So we don't have the scientific number on that yet. So what about other doctors? Do you have any questions or some of your experience? Just feel free to share them.
Can I say something? This
Yes.
is Dr. Chen from New York.
Mm-hmm. Please go ahead, Dr. Chen.
I'm a primary care physician, 家庭医生, and I see most of the cases actually like mild to moderate, and we can manage them in their home. There's a great difference from US and to China, because I worked in China many years ago. So with 8 years experience, actually practice medicine in China. And now I'm here. So I know the system is totally different. And now I'm a primary care in US and particularly in New York, the epicenter. We've seen many patients and we manage them at home. I do follow one case very close. I have all these pictures of pulse oximetry from beginning after 1 week of the onset of the disease, and his O2 sec dropped to 87 to 88 on no more. And when about day 8 to day 9, he reached out to me. So I evaluated him and I give him all this advice. And after he's starting taking the hydroxychloroquine and Citromax, I give him another dose, not another dose, the right dose. That's what we have this recommendation most in this community. And another important thing, I give him a lot of vitamin, huge antioxidant. So that is why the Chinese traditional medicine, maybe some help, like Dr. Xiao Mao say, could from antioxidant. And most of those severe cases, actually, at the end of the day, will be cytokine storm, and it's most inflammatory reaction. So when you have a lot of antioxidant material in your body, it will reduce your free radical, then reduce this cytokine storm. That's one important thing. And the second, we start oxygen therapy earlier, much earlier. When I see him deteriorating, I just order the home oxygen tank, the concentration and oxygen. He is managed very well at home. He's a 63 years old man with hypertension, some underlying medical problem, but he did really well through the whole course. About 4 weeks, is rolling back to normal. I want to have another comment is, those patients, they more or less have some cardiac damage, particularly with the patient with hypertension, with diabetes, with other comorbidities. And these patients' heart rate is very fast, up to 109 per minute. He used to have beta blocker in the past by his previous doctor, and I changed to calcium channel blocker, the calcium short term, 60 milligram TID, and able to manage the heart rate come down to less than 100, 90, and nowadays it's about 70 and 80. And his oxygen, I had to use up to 6 liter per minute to manage his oxygen level up to 95, 96. So my question is to the Chinese counterpart, how well you know, how well you treat the patient at home with home oxygen therapy? Because I just heard the news lately. We justified the death at home more than 3,000 patients, because some of those patients died at home. No one knows. And I know the system is different. And I believe when Chinese government promote the primary care in the Chinese healthcare system, could prevent those deaths. And that's our experience in New York. That's my question is, do you use home oxygen to treat the patient at home? How do you monitor them? What is the criteria you call here? We call 911. I think in China it's called whatever the number.
It's 120. Yeah, it's a different number.
Yeah, 120. Okay. When do you call ambulance to bring the patient to the hospital? Because you don't want to bombard the hospital. You don't want to use up all these resources. You better manage those patients at home to the point you just can't do it. Then you have to refer the patient to the hospital. That's what we do in here.
Okay. Okay, Dr. Chen, well, the situation here in China might be different from that in the States. Maybe we don't have patients like but I'm not fully sure. So I would like to turn to Dr. Xu or which doctor could answer the question. But I'm pretty sure the situation of COVID-19 patients is very, very much different from that in the States. Okay, please go ahead, Dr. Xu.
Okay, please let's. Okay, I may answer the question. Yes, definitely. If the patient need oxygen, well, when the patient discharge, we'll ask the patient to buy the machine to make a family oxygen treatment. And we will use the monitoring machine and monitor the oxygen saturation. We will tell the patient the SaO2 will maintain between the at least 19 and the 19 at least. The battery is 95 to 98. So if the patient have this oxygen problem, they will buy the oxygen machine to go to home and monitoring the SaO2. Yeah. When did they call the 911 or 999 to oxygen ambulance? It depends. It's I think when patient feel they can't control this, they feel uncomfortable, and they are upset. They can always call the 911 or 999, the ambulance. I think it's people in China call more ambulance than U.S. Because different countries
treating
have a
system.
different system. Yes.
Mm-hmm.
Thank you. My next question is: do you know how this antibody testing? Because now China is completed this the pandemic at the end, really end. So how do you monitor those patients? Do you find any surge of the population with antibody? And how do you use this antibody test like IgM, IgG, particular IgG, to make sure the patient is immune or not immune? How do you interpret the IgG test? If the test is positive, what do you do? If the test is negative, what do you do?
Okay. We check the IgG and IgM for the virus. The IgM antibiotics will find after the fly up 3 to 5 days, and IgG will increase in 2 weeks. So we use the IgM mostly for the earlier diagnosis, especially for those suspected patients who with one time or several times nucleic acid test negative. So we use the IgM examination to confirm this diagnosis. And for the IgG examinations, we will confirm those patients. We'll find this patient who have been infected the virus, because some of patients may have the asymptomatic, no symptom. So this is help to find this patient, and which IgG examination will provide informations like a proportion of the herd immunities, or as a criteria for blood donors. I think it's IgG's its utilities. Thank you.
Thank you. I have last question. Is to our Chinese consul in New York. I have
Councillor Zhou, I think there's a question for you.
Councillor Zhou, 周先生，你好。We have when China, Wuhan have the pandemic, as a Chinese American physician in here, we collect a lot of PPE and masks and gowns, and we help China. We raise a lot of donation and help through our organization, and all of us in here are part of this movement. And we will kind of easy to go into China. Now, when we need those materials, the PPE, the protective gown, and even the antibody test, we find a very difficult time to get them to US. And I would like to see if the Chinese government able to expedite the export, those materials, the PPE, the masks, the gowns, and the antibody test, particularly, we are very interested in the IgG and IgM testing to American population. If we are able to expedite those export to here, we could test the population, see if they have a long-term immunity or if they have recent infection, and like Dr. Su say, we could have some kind of a prediction and some kind of a preparation for the next wave of the pandemic. Or we could use those one who developed the antibody, use the plasma to treat those people who in a very critical ill to save life. So we are trying to get something from China at this time, but we have experienced very difficult time to export those material to the US soil. Thank you.
It's a very tough question, especially given the situation now. The logistic might face many challenges. So, Councillor Zhou, do you have any response to that? It's a really tough question, I know. And you need to turn on the audio. You need to turn on the audio.
We experience that, and we want to help because we are a primary care. We are the doctor in the front line and treating the most of the population, 80%. We're not hospitalists. So we are on the ground fighting this virus.
Yes.
Thank you.
See, what we have been trying to do is even in the, to your point, in February, in March, when the situation in China, in particular in Wuhan, was very serious. So there are so many foreign people, including our fellow Chinese people in the States. They have helped China quite a lot through different ways. We are so grateful for all of your efforts that you have already done in the past. Of course, we will remember that during these days, starting from March, now this is late of April, the ambassador, Mr. Cai, the ambassador of China in the States, as well as Mr. Huang, the ambassador of my consul general in New York, they have already been seeing reporters quite a few times to express their kind of ideas what Chinese government has already been done in the past few months of time. Actually, now this is quite a fierce competition between different countries to get all of such kind of materials, PPE or ventilators or gowns or masks or whatever. Not only in the States, but also in the European countries, and even in America, different states have a kind of situation of shortage of this kind of equipment. So the government of China, we have been trying our best to export to the recipient countries, including the United States of America. So you see in the past few weeks of time, the Consul General here in New York, we have been promoting, try to facilitate the process of buy-in, help Governor Cuomo and Blasio, of the mayor of New York City, to get such kind of equipment as soon as possible, as much as possible. Not only this city of New York, also other states in this area, because the Chinese Consul General in New York, we cover 10 states, including the state of New York, and also New Jersey, Massachusetts, Ohio, Connecticut, Rhode Island, and none of others. So these are all of the states. They all require it. They all need it. Of course, we know New York City is the most serious place. Your hospitals is really in the shortage of sort of kind of equipment, and we are trying to do our best. So this is the situation. I think a few weeks ago, maybe 2 or 3 weeks ago, you still remember that Mr. Cuomo, the governor of New York State, he had an interview with the television that the Chinese organizations have donated some 1,000 ventilators to New York State. You may still remember that one, and as well as others. I don't, at this moment, I don't have such kind of figures in my hand, but I still remember there are more than how many masks have been exported and donated to the United States. It's more than, I think it's more than 9 billion. I don't remember the figure. It's a huge number. The masks, the PPEs, and the gowns, and the ventilators also. Ventilators is about 5,000 something. It's not that many because we are just make the full range of the production of the lines in China, the factories, but it's still in the shortage. The United States need it, the European countries need it, the Russians they need it, whatever, and even in South America, people they need it. Asian countries need it. Every country they're in the shortage. So this is the way. Anyway, through my general consulate here, we are trying our best. Myself, as the Counselor for Science and Technology, we have been persuaded. You see, we've been asked to help. We have trying to do our best. Some of the hotel, some of the hospitals, some of the institutions, whatever. We hope that this will be better. You see, I heard the news that the ship, the naval ship, the ship is going to be getting away because New York City maybe don't need it anymore. Because as Dr. Lee just mentioned, that the curve is flattening at the moment. So we really hope that the situation is becoming better. Because I am one of the persons living in Manhattan, so we are also facing the very similar problem situation as you do. So then we hope everything will be fine anyway. I hope my answer will be somehow meet your requirements anyway. Thank you.
Short comment. Russia is very thankful for the recently sent 5 million masks and some PPE to Russia. So it helps us. It's not critical, but it's helped us.
Yeah, and especially thank you, Professor, and thank you, Counselor. Especially during, a critical time like this, it's always good to see countries standing shoulder by shoulder, extending helping hand with each other, and to help each other getting through, a challenging moment like this. And now, how about let's turn to Dr. Leibowitz. So, do you have a question for the Chinese doctors? Maybe you can go with one. You need to turn on the audio, Doctor. Thank you.
Okay.
Now you get to. Now it's good. Yes.
Yeah, I'm good. How are you? So I have a question for our Chinese colleagues, and perhaps even Dr. Jin Lee, who has started from the beginning in the United States. The question is this: what and I'm doing this since it started in New York. I'm in Brooklyn with Dr. Chen, and we've seen a lot of cases. I've seen a lot of severe cases in my inpatient practice, followed them to the hospital, et cetera. So the question is this, short and sweet. What is your experience? And this is a concerning question for us because I'm seeing positive cases 5 weeks out, negatives that turn positive, people who feel fine but are still infectious, and positive on nasal swabs. What is your experience with what we're calling either reactivation or reinfection, relapse, and the role of antibodies in all this? Are they protective? Is the virus sitting in our tissues like herpes zoster that would reactivate as shingles, or is that the case here, or it's really a one and done, although extended? So reactivation versus reinfection versus protection. Where are we? What do you guys know from China?
Okay, so who can answer that question?
You mean the rate of the? You mean the question is the reinfection of the COVID-19?
Reinfection and or reactivation.
Reactivation. In our hospital, in our patient, in China's patient, we find some patient have the very low reinfections of the COVID-19. Most of them reported is when they discharged or some patient still in hospital, the testing become negative and positive, but most of the patients, the clinical status is stable. So it's not very. I think it's not very important question. Today I saw a report from the South Korea that 80% of the discharged patients, the tester is positive, but this patient no relapse, no transmissions. And in China, Guangdong province, there's a discharged patient. 40 patients of the discharge, they have the positive, the test positive again, positive. So, but all these patient clinical status is stable. I don't think this reinfections is a problem. Maybe it's something examination problem, and
but are
maybe
they still contagious? That's really that's where the problem comes in. That they're discharged and they feel fine, and are they not transmitting because they're isolated, they're sick, or whatever reason they're still home? If they would be let out, would this reinfect the other 80% of the population?
Yeah. We care about this patient transmissions problem. So when the people discharge, we will ask them to isolation for another 2 weeks. After that, we ask patients, when they go outside or contacted with family members, you should wear masks to protect the family members, to protect the other people's and wash their hand. So that's I think that's a very important measures to protect to stop the transmissions.
Yeah, and also I heard Dr. Xu, right? So for those people, especially for the patients here in Wuhan, so for those patients who were discharged from the hospitals, we don't let them go directly back home, right?
Yeah.
We sent them to another places such as a hotel for 2 weeks of quarantine, and after 2 weeks, and you have another test before they or sent to home, right? They have another test. And if it's positive, they can be sent back home. So it's not like directly discharged from hospital and then to home. They have like a 2 weeks quarantine.
That's something we should probably be doing here, which we're not necessarily doing.
At the beginning, we have the patient discharged and they go back to home to isolation. But after that, we find some discharged patients, they have a test positive again. So we change our rules. So the patient have to, when they discharge, they have to go another location to isolate for 2 weeks. After that, we test. The test is negative, and then go back to home. Yeah. So we have,
Okay. Thank you. So just a short break from our expert discussion, and now let's take a look at the big screen to see some of the comments and questions we have got from our followers on various social platforms. So how about let's take a look at the second one, number 2. So the question is how to test to see if someone has had COVID-19 and recovered without knowing. Do asymptomatic carriers have antibodies? What's the difference between them? Wow, it's a long question. So maybe not only the Chinese doctors or doctors in the US or professor in Russia, do you have any experience or something that you can share with us? So basically do asymptomatic carriers have antibodies? And how to test if someone, they already had the COVID-19, but now they recovered, how do we know that?
So I could give like an answer here. I've had a number of couples where the husband was deathly ill and the wife was taking care of the husband without a mask, and oddly enough was not sick whatsoever. And after the husband's recovered, came back to the office, I re-swabbed the husband, and I said, hey, let's swab the wife, and I got some antibody testing at the same time. The wife was positive, but interestingly enough, and this is what I find very fascinating, is the wife is very weakly positive on an antibody test and positive on swab. The husband's obviously strong antibodies and positive on swab at the same time. which for me is very curious. So the wife is obviously infected and really not showing any symptoms. And we know this is somewhat of an immune disease. And I'm just thinking perhaps the fact that she's not making antibodies was a good thing as opposed to a bad thing. And it's a very confusing situation because you would think that, hey, if I got a lot of measles antibodies, I could walk in a measles ward without a mask and be fine. But in this case, if you have a lot of COVID antibodies, you're in trouble. This sort of remains to be seen. But the issue with the IgG test for the social media people out there is that it's not necessarily specific for COVID-19 and can test for other coronaviruses. That being said, I myself have no IgG on this particular test, and swab is negative, so hope to remain that way. That's how you find out.
Hopefully.
When we find out a specific IgG for corona, if it's out there, if it's going to be out there, that would be a way to know if you're a carrier, has been infected and never had symptoms. Short of that, do the test, hope it's COVID-19, and/or swab to prove at the same time that you have it, are asymptomatic, and indeed you have antibodies.
Okay. Okay, thank you so much, Dr. Lebowitz. So maybe doctors on the Chinese side, do you have any? Yes, Professor. Yes, Professor, please join.
First of all, our testing, because we have second by number testing in the world, in Russia, show that more than 60% of the SARS positive patients have no symptoms at all. So they are like people who never knew about the SARS, about the COVID-19, and they are only revealed on the special testing on the enterprises or in the business some facilities. First of all, that's first. Another testing of the medical personnel in one of the our highly qualified clinic in Moscow showed that medical personnel in this clinic had about 3% of this medical personnel has IgG antibodies in their blood, but never have SARS tests, and SARS have SARS negative. So it's very interesting because perhaps in our population is natural resistance to the SARS, like it is for hepatitis C or B, for HIV virus. So it's we don't know now. We have more broad investigations now. We have in Russia special tests for these investigations. Very soon, I hope in 2, 3, or 4 months, we will have very good data about what is the real immunization of our population in Russia. I hope it will be in China too, and in United States too. So it's let's wait. It's a scientific question. Will it be next wave of the SARS epidemic, or it will be seasonal disease like it's like influenza virus? So let's see.
Yeah, let's see and hope for the best and waiting for this result. So the doctors on the Chinese side, do you have anything to add on that? Or we can go to the next question. So maybe we can go to Dr. Dr. David Zhang. Maybe, do you have a question for us?
Hi, everyone. We are in New York, and I'm working together with Dr. Chen together and serving the community in China, in New York. And in our community, we have the vast majority are Chinese dissidents and the immigrants or their family members. They have roots in China, and about 80 to 90% of people we serving are Chinese, and we have some disproportionately infected rate, and the rate in the Chinese community are relatively lower compared with other ethnic group, and this is attributed to the effective communication between the Chinese in New York and the relatives or the friends in China. And thanks for the WeChat, which transmitted a lot of information to people in New York. And due to this reason, and the people are well prepared in terms of for social distance, in terms of mask, which is probably the primary preventive measure the people in New York taken, and therefore the infective rate is relatively low. However, we do have people infected, especially in nursing home and in the crowded community who live in the city and with a large family in a crowded space. I often receive the comments from my colleagues and also from my patients, and they're asking about what is the other way to prevent or treat COVID-19, and which has been mentioned, the Chinese medicine. We have the root in China, and a lot of people understand, by tradition, and they use quite a lot for alternative measures. And my question to Dr. Xu is that seems to be it's very high rate of a patient in China being treated with the combination of Western and the Chinese medicine. And you mentioned about over 90% people. And I also realize that the COVID-19 guidelines published in China also including the Chinese medicine. The question for you is that do we have any solid data regarding the Chinese medicine? And you mentioned that it helps, but in what level? In the mild symptoms, or it is severe patients? And there's any trials going on in China to support the use of this Chinese medicine or Chinese measurements? And the final thing is that how are we going to recommend to the community in New York and who do not have access of some of the Chinese medicine which recommended in the COVID-19 guidelines?
Okay, thank you, Dr. Jiang. Because the three doctors that we had today are either pulmonologists or ICU doctors, so I'm not sure whether they have the data. We can ask them. But maybe if you want to know more data, because actually before we had live streaming, especially focused on traditional medicine, the treatment, the combination of Western and traditional Chinese medicine, and we have academicians join our show before, so maybe we can send you a link afterwards. I think they have more explanation as well as data showing us the result on that front. But we can ask Dr. Xu or Dr. Wen or Dr. Chang about their experience at the front line of combining Western medicine as well as Chinese medicine. Do you have the data, or do you have a trial, something more scientific with more solid conclusion? So who can answer that?
Okay. I can't actually tell the data how many patients uses Chinese traditional medicine, but in my to my knowledge, most of the patients uses Chinese traditional medicine. But it's a pity we do not do some research like RCT research to combine. One group use Chinese traditional medicine plus Western medicine, and another group use a placebo or just to use a Western medicine. So we don't do that research for my known. Most of the patient, it's a mild, moderate, or severe patient. If they can eat or they can drink eat the medicine, we will give this Chinese traditional medicine. And in our team, we have Chinese traditional doctors with us, so they can see the patient personally and give their personally Chinese traditional medicine. That's I think is very helpful.
Okay, thank you, Dr. Xu.
Can I just have a comment over here, a question? When do you guys start treatment for patient? Like over here, we prefer to delay treatment till the patient is really very sick. We don't give treatment for a stable patient with positive testing or for early stage with minimal symptom. And the other question, like we're doing a lots of trial on IL-6 inhibitor over here in the United States for people who are sick on mechanical ventilation as a trial, like to see if it works or not. I know you guys have a good experience. The last question, I know you guys have at first like we have lots of report from for the use of favipiravir, I think the name of the medicine, which is not approved over here in the United States. Can you comment on the benefit of that medicine also?
Mm-hmm. So who can answer that?
Dr. Chang, please answer this question.
You mean the IL-6 antibody?
Like tocilizumab and...
Yeah. Yes, actually, in our patients, we routinely test the patient's level of IL-6, and we found most of the patients during their during the COVID infection, the IL-6 and TNF alpha and ferritin IL-2 are pretty high for a period of time, and we tried some cases with the IL-6 antibody like tocilizumab.
Yes, that's what we're trying over here.
Yes, we tried some cases, but only several cases is not enough to make a statistical analysis. But in China, we have a 7th edition of treatment guideline. I remember in the 7th or maybe the 6th or 7th edition, the tocilizumab is recommended for the doctors to try. Yeah, I'll be glad to see if other doctors to publish their article one day. Also, I heard some we have some doctors, they try to use a CRT for critically ill cases with inflammatory storm. Yeah, I think I'll be very glad to see when they publish their article.
And were you guys starting treatment early in the disease, or same what we're doing over here? Like you wait till the patient is very sick to start them on treatment? Like when you swab with minimal symptom, would you immediately start them on any kind of treatment, or you just wait till you see the progression of the disease?
You mean when we will use the IL-6 antibody?
No, when will you use any treatment, like hydroxychloroquine, any kind? Caletra, we're using over here. I think over there we're using lots of favipiravir. When did you start those kind of treatment? Like immediately when you find somebody with minimal symptom, or you wait till they have a respiratory symptom to start them on treatment?
Probably.
The question is early treatment versus late treatment for the disease.
Professor Xiaomao, you can answer that.
No, you're still mute. You're still in mute. Dr. Xu, we still can't hear you. Okay, now it's good.
Sorry, just now the sign is not very good, so I can't hear the questions. Can you speak again?
Yes, my question, I guess, was usually when somebody have a mild symptom, we do the swab for them. The swab is positive. Over here in the United States, we ask to go home, do self-quarantine, and we monitor them. If they progress and start having respiratory symptom, we start them on treatment. Otherwise, we just ask them to stay home and self-quarantine. Did you do the same approach over there in China, or did you guys start them on treatment immediately when you have a positive testing for them?
Yeah. So if this patient is a positive, we should have to, if this patient is a mild patient, we don't let him go home, because at first with this patient go home, but it's dangerous for the family because the house is not very big. So will infect the other family members. So after that, in the hospital, we will receive the patient is moderate to severe and critical patient. So the mild patient, after that, we will let him go to the gym, some capital, to make a simple hospital to let this patient in there to prevent them to infection their family and their friends.
Mm-hmm.
But did you guys start them on any medication or just observation?
Like for mild symptom patients, or patients who show
we
just
will give
little
some
sign.
Yeah, we will give them medications. We'll give some Chinese traditional medicine, or some maybe they give some antibiotics. Yeah, and we will observation this patient. If this patient gets sick, and we'll go to transmit it into the hospital.
Can I ask a question here? Just follow up on this. Is we've been doing this, since March. You guys have been doing it since the end of last year. Everybody has their favorite drug, which they think works, but it's really all anecdotal and observational, uncontrolled. Patients telling me their garlic cured them, and patients who took nothing and they're better, and other patients die. Remdesivir is a miracle, then it's not. We're all over the place. Do you guys, in all of your experience, bottom line, do you guys have any drug that is a clean knockout? That, hey, this guy really works. Is it hydroxychloroquine? I guess not. Remdesivir, maybe. The HIV drugs, plasma, does plasma work, or is that just another dud? Have you guys done plasmapheresis, looking at the other end of things, or any true knockouts? Anybody that knocked this out of the park that you could say, hey, this is really the target, or you guys are just as lost as we kind of are here?
Okay, Dr. Wen, please answer this question.
So Dr. Wen Li, maybe, yes, now you're good to go.
Okay, thank you for asking, and let me ask you a question. You want to know which of those therapy and medicine and ways could stop the epidemic and make symptoms elevate, right? And as far as I know, I think the best way and treatment to stop disease is quarantine and steroids. And I found the turn point in China is begin with the how to say that, mobile carving hospital, right?
Temporary hospitals. Yes.
Yes, temporary hospitals. And when this must start and the whole conditions turn to good ways. So, and this is a side of this answer. And another about the medicine. In our guideline about COVID-19, we have 7 addition about that, and we have recommend many medicine in those guidelines. But actually, in our therapy course, in our ward, in our patient, no one of them shows exactly much better than others. Could you get that? And someone says the chloroquine, and in as far as I know, in US, someone very recommend the hydroxychloroquine, and another therapy like remdesivir, and you use that? Have it been marketed? I don't know, but in China, chloroquine, we use chloroquine phosphate, not hydrochloroquine. Chloroquine phosphate we've been used in our ward for about maybe more than 50 patients. As far as I know personally, I haven't seen anything better about it than another medicine, right? And I've heard recently some adverse effects, especially in the cardiac system, have emerged, like these arrhythmias, like heart failure, and lucky we did find them in our patient too. So about chloroquine, it's not in my regular treatment regimen in this stage. And
So you have no knockout. You have no real home run with this. It's basically the world has to lock down for 2 months, let the disease die out, and then we're done.
Maybe it's really hard for a doctor to say like what is this knockout, right? Maybe it's hard. Every medicine has its advantages, strengths, or it also has its disadvantages. I don't know. Or other doctors, do you have anything to?
No, I know it's hard. That's why we're all searching.
Yeah.
Yeah.
So
yes, it's just a personal opinion, and I didn't have any knockdown medicine for this disease. And how about remdesivir? How's your opinion about that? Did you ever use it?
I'm not in the ICU, but patients who have gotten it are no better. And my patients, I mean, some are reportedly better. Mine didn't do so well. So again, we're looking, randomized control and all that stuff, which we're not really getting much information at this point yet.
Okay, we are in the same condition.
Briefly, we in these 2 months we use a lot of the antiviral drugs, like HIV drugs, like the Oseltamivir, like ribavirin and interferon beta. But I don't think there is very effective drugs, including HCQ. So we still have a lot of job to do some randomized study like the HIV drugs and remdesivir virus. Thank you.
Okay. Thank you, Dr. Wen and Dr. Xu. So due to the time limit, we might only have time for a final very few questions. So who has a question? Just feel free to raise them.
Can you give us a little bit of your experience in ICU on ventilated patient when you reach the level that you're not able to oxygenate them, the role of PEEP, what kind of vent mode we're using? We know the strategy should be a little bit different than what we use for regular ARDS patient. So how was your experience with those people in ICU? What did you do to be able to ventilate them in a better way, to oxygenate them in a better way?
Mm-hmm.
Yeah. So the COVID-19 treatment includes, the antivirus and respiratory support and the organ support for severe and critically ill patients. The most controversial aspect is what we just discussed is about the antivirus. Actually, the main treatment in the ICU is respiratory support and organ support. So we tried oxygen therapy, includes a nasal cannula, oxygen mask, high flow nasal cannula, and non-invasive ventilation, mechanical ventilation, and ECMO. We will use as usually step by step from nasal cannula, oxygen mask to high flow and mechanical ventilation. So the cannula and oxygen mask and high flow is pretty commonly used, and the most controversial topic is about the time of invasive mechanical ventilation. Currently, in our early stages, many doctors would use the non-invasive ventilation for pretty relatively long time to avoid for invasive mechanical ventilation. But after the experience is more, they would suggest that we intubate the patients more early to prevent from the non-invasive ventilation induced lung injury. So currently, if you use non-invasive ventilation for 1 or 2 hours, if you can see the respiratory rate is still high and all the patient tidal volume is high. Example, over 1,000, or the pulse oxygenation is pretty low. So you have to change the patient to intubate as quickly as possible.
Okay, thank you so much, Dr. Chen. And before we conclude today's dialogue, I just wonder, the doctors from Chinese side, do you have anything to share or something more to add? So if not, we'll just...
And, yeah. And for the mechanical ventilation, for the usually we use 2 types of method. One is some patients may be used to typical ARDS. So we usually use the prone position and lung recruitment and and the lung protective ventilation, and another type of patients whose the lungs is pretty different from those patients with typical ARDS. So for these patients with early stages of hypoxia, the main method is use cannula and high flow.
Okay, thank you so much, Dr. Chen. So, Dr. Wen or Dr. Xu, do you have more to share or to add at the ending of our dialogue?
No, I'm very pleasure to have this time to share our opinion, experience with American doctors. I hope for you guys will take care of yourself. Thank you.
Okay. Thank you so much,
glad
everyone.
to hear the sound from overseas, and hope everyone's well, and hope you're good.
Okay, thank you so much, everyone. And with that, we're going to wrap up today's discussion, in which doctors, medical workers, as well as distinguished guests from China, the United States, and also Russia joined in this dialogue, exchanging ideas and also sharing some of the experience on the most pressing issues concerning COVID-19. And hopefully the consensus reached today, as well as the information shared today, will help different countries to avoid detours and also fight better in this battle against COVID-19. So thank you so much, everyone. For doctors joining us, and also thank you, Councillor Joe, for joining us and supporting us. And we'll have more to come in the upcoming days. So stay tuned on CGTN and also stay tuned on COVID-19. Thank you and enjoy the rest of your day.
Thank you.